Hello viewers, thank you for joining Alpha One Canada's 2015 Virtual Education Summit. My name is Duncan Lam and I'm your host. We're very happy to have our speaker here today, Dr. Kenneth Chapman, the Director of the Asthma and Airway Center at Toronto Western Hospital. Dr. Chapman will be talking to us about asthma, COPD, and the asthma-COPD overlap syndrome. Without further ado, let's proceed to Dr. Chapman's presentation.
I've been asked to talk about the asthma-COPD overlap syndrome, or as lung doctors shorten it, ACOS. What I'll do in the following presentation is review the following subjects. First, what is COPD? How do doctors define it? Next, what is asthma, and how do doctors define it and separate it from COPD? And then, of course, finally, what is this asthma-COPD overlap syndrome, or ACOS, and how are doctors meant to puzzle it out as compared to just plain COPD or just plain asthma? What's different about patients with ACOS? And as it turns out, their characteristics are a bit different from straightforward COPD and a little bit different from straightforward asthma. The important thing is it means that there are going to be some treatment differences if patients are diagnosed as having ACOS. Now, all of this will be a discussion about asthma and COPD in general, not specifically about alphas until we get to the end, and then we'll try to see what difference this might make to the treatment of people with lung disease due to alpha-1 antitrypsin deficiency. I'll get to a summary and hope to wrap up this 15 or 20-minute presentation in just a few sentences. So what is COPD? Somewhere in your reading about COPD, you may have encountered the term chronic bronchitis. It's an old term. It's been around for at least 50 years, and it used to be standard medical school teaching. In fact, it probably still is. Unfortunately, it's not a very useful definition of a disease. It turns out that when doctors say chronic bronchitis, they're describing somebody who has a cough, as it says here, productive cough, for 3 months in each of 2 successive years. Well, a lot of people cough, and may cough for a number of different reasons. And in fact, the complete definition is chronic bronchitis is a cough that continues as described as long as the cough doesn't come from something else, like asthma, or a lung disease like bronchiectasis, scarring of the lungs that alpha patients can get, or pulmonary fibrosis, or tuberculosis, and so on and so on. In the end, it's a very simple definition that ends up not being very useful. It may be worth bearing in mind, though, that your doctor may have gone to medical school when this was the current teaching. Let's leave chronic bronchitis. Another term you'll hear is emphysema, and of course this is very important to alphas, and we have some great definitions for emphysema. The standard one is what you see there: abnormal, permanent enlargement of the air spaces distal to the terminal bronchioles. Now that's not only very technical, but it's also not very useful, because the only way one would find this abnormality is with a lung biopsy, or perhaps with a CT scan of the chest, and we don't use that to make our diagnosis of emphysema clinically. It's certainly not something that's going to be used in the family doctor's office. So I've just given you 2 rather old definitions that your doctor may be working with. And as a consequence, your doctor tends to default to what's simple, the stethoscope. And there's a myth about the stethoscope. We send medical students to the bedside for years to train them how to listen to noises they might hear through those rubber tubes and intuit from that what sort of disease is present. As it turns out, finding a lung disease and diagnosing it with a stethoscope is pretty tough, in fact, just about impossible. It's a technology that won't find COPD early, it won't find it accurately, and we suspect a whole lot of people are not getting treatment they need because their doctors rely on a stethoscope, or are getting treatment they don't need because their doctors have relied on a stethoscope. Just to understand what we would like doctors to detect, you can look at these drawings. On the left, what you're seeing is an artist's rendition of an airway, a breathing passage deep down inside the lung. You'll notice that that circular, open breathing passage is suspended in a network of lung tissue. That's the lung parenchyma that gets damaged with emphysema. The tube on the left, the normal one, is wide open. It's lined with a little bit of epithelium, we call it, the normal barrier that protects the lung from the outside air and particles. You might notice, if you look closely, some mucus glands that produce a small amount of normal mucus that is present in healthy airways. But skip to the right, and you'll see quite a different picture. This is the artist's rendition of COPD, and there's several things that are wrong with it, and in fact, there may be different things wrong in different individuals with COPD. Some of the outside labels point to damage of, as it's phrased here, alveolar attachments. That's emphysema, damage to the lung parenchyma. That's the prominent injury in people with alpha-1 antitrypsin deficiency. But move to the center of the photo or the drawing. It's meant to be a wide open airway. In fact, the airway wall is thickened with what doctors would call inflammation. There are more mucus glands and there's more mucus in the airway. By the way, these are artists' drawings, but we can look at the actual pictures as might be seen under a microscope. And as you can see, there's the healthy, open airway on the left and the very thickened and narrowed airway on the right. And that narrowing is what we call obstruction. It means that when one breathes in and breathes out, the airflow is slowed down. And we can measure that airflow, and we measure it with a simple device called a spirometer. I suspect that just about everybody listening has undergone spirometry, but just to pause for a minute, it's old, simple technology, but it's very reliable. We measure how much air comes out of the lungs when somebody exhales forcefully into the device, and we also measure how quickly it comes out. If there's slowing of the airflow, we term that obstruction, and that's what we want doctors to measure. When they find obstruction, they're finding a lung disease. The characteristics of that obstruction and how it responds to treatment are going to tell us a lot about which particular lung disease it is. So with that background, let's move to the current standard definition for COPD. You'll see reference there, the GOLD, or the GOLD strategy, which helped to define COPD in a simple, practical, clinical way about 15 years ago. The authors of the GOLD document said, COPD means that airflow obstruction is present. That's a very simple statement, but a very powerful one. It says doctors need to measure airflow if they are going to make a diagnosis of COPD. This next part you probably don't have to pay too much attention to, but doctors can measure a specific set of numbers, the FEV1, the FVC, and their relationship to one another, and in fact, they're looking for one specific number. If that ratio that you see is below 0.7, it means somebody has reached the benchmark that is consistent with COPD. The next part of the diagnosis is that the person suspected of having COPD has been exposed to something bad for the lungs, as it says here in rather torturous terminology, chronic exposure to a noxious substance. You might say, well, why didn't they make that simple? Why didn't they just say tobacco smoke? But that's a very Western nation definition, where tobacco smoking has been common. In other parts of the world, the noxious substance might be the smoke of cooking fires. So it's meant to be a broad international definition. And then finally, this next part is very important. The obstruction of COPD is not completely reversible. So we can give medicine, we can improve the lung function a bit, improve the airflow a bit, but we can't make it go away completely. And that is the thing that distinguishes COPD from asthma. So of course we're now on to our next section. What is asthma? For years, doctors have been given a complicated set of guidelines for distinguishing asthma from COPD. And I'm putting up this table with some misgivings. I don't like it. So for example, if we look at the top row, it says asthma, well, that usually starts under 40 years of age, and COPD, well, that usually starts after 40 years of age. And of course, that's nonsense. People with alpha-1 antitrypsin deficiency listening to this will know that their COPD can begin quite early. And in fact, we even understand that some patients' COPD starts very early, even without the presence of alpha-1 antitrypsin deficiency. And as for asthma, yes, it occurs in childhood, but it also starts up later in life. So that table, certainly the first row, is not very helpful. Similarly, smoking history is not very helpful. We know that alphas, for example, can get COPD without smoking, and we know that people with asthma can sometimes smoke, and it makes their asthma difficult to treat, but it doesn't make their problem COPD, and so on and so on. I'm going to highlight the revised table. The revised table makes this a little bit more realistic, and finally I want to highlight that second to last row. That row brings us right back to spirometry. And I said before, that was something we wanted doctors to be using. And you'll see the thing that distinguishes asthma from COPD is that when we treat asthma, we should generally be able to make that spirometry normal. But if it's COPD, although we might improve the spirometry, it doesn't become normal. And that's a clear distinguishing feature between asthma and COPD. Now that we know what asthma is, what COPD is, what about this overlap, or ACOS, asthma-COPD overlap syndrome? You might be reading about this online, or perhaps even hearing about it from your doctor or specialists. That's because recently the Global Initiative for Asthma and the Global Initiative for COPD groups got together and prepared a document which they published online. They finally acknowledged something we've known for a long time. Some people have asthma, some people have COPD, and a few people in the murky middle have both. Now, I'm going to move through the next few slides quickly because they're rather complicated, and it's just to point out that this asthma-COPD overlap syndrome is a work in progress, and what's being published online is a little bit complicated, and probably more complicated than is useful for the average busy clinician. So, here's another one of those complicated tables Don't worry about trying to read all the little boxes, but I'll just point out that where we once had a table that showed features of asthma, features of COPD, with a comparison of the two, we now have a third column, the features of ACOS, which is basically a little bit of each. As you can imagine, trying to work one's way through this complicated table makes it difficult for a doctor to arrive at a clear answer. What does my patient have? We could try and restrict our analysis to breathing tests and spirometry, and here it is outlined, and even this is a complicated table, and again, something that might not be helpful to your average clinician. You'll notice, by the way, if you do read through this table, that there are 2 or 3 possible definitions of ACOS based on spirometry. There are some other fancy tests that can be done. Some of them are done in an ordinary laboratory. Some of them are not done except as part of research. For example, exhaled nitric oxide, measurement of inflammatory cells in sputum. If you seek care at a specialized center, some of these tests might be available. Again, though, they're a work in progress. They're not part of a well-established definition of ACOS. And then finally, believe it or not, this long and complicated algorithm, this pathway, is meant to guide physicians to their distinction between asthma and COPD. As you can hear from my cynical description, this is also a pretty complicated pathway for clinicians to use. I want to bring us back to one of the things we said earlier about asthma so that you can understand what I would suggest as a working, practical definition of ACOS. Now, these pictures might not be too familiar, but trust me, the picture on the left, which is a biopsy of an asthma patient's airway, is quite abnormal looking. If you do know your way around a microscope, at the bottom of that picture on the left, there are lots and lots of little circles. Those are inflammatory cells, a lot of eosinophils they're called, and they're causing redness and swelling of the asthma patient's airway. Up at the top, there should be some cells that have little hair-like projections on them. They're called cilia, but it's pretty hard to make that out because the epithelium or lining of the breathing passage has been so badly damaged by the inflammation below. Look at the right. What you're looking at is a textbook picture of a healthy-looking airway. But these are pictures from the same patient with asthma. On the left, before treatment. On the right, after treatment. So again, key in distinguishing asthma from COPD is that with good treatment, we can make the airway normal and we can make the lung function normal. So here's what I'd suggest for doctors and their patients trying to puzzle out what sort of obstruction somebody has. So let's say your doctor hears some wheezy, whistly sounds in your chest and you're having breathlessness. A spirometry is done and there's obstruction. So that term at the top, OAD, that's obstructive airways disease. But at this point, we're not sure what it is. Could it be asthma? Could it be COPD? Well, if you're a smoker, as the first box suggests, you've got to quit. And the next box on the right, therapeutic trial, you get some medicine. But if your doctor's done a spirometry, a measurement of your airflow, and let's say it's only 50% of what it should be, your doctor, after that therapeutic trial, should measure again. Let's say, as a working rule, somewhere at the 3 to 6 month mark. If your airflow hasn't changed very much, that is, if it started at 50% and rises to 55 or 56%, that is consistent with COPD, obstruction that persists even after our treatment. And we'll think of you as having COPD and follow our COPD treatment strategies. But perhaps at that 3 to 6 month mark, there'll be a dramatic improvement. The airflow, which was 50%, is now 90%, normal or pretty close to it. In that case, we know that we're dealing with asthma, and we'll follow the asthma treatment strategies. And then finally, there could be something in the middle. There could be a very big improvement. The 50% airflow rises to 70% airflow, but it doesn't return all the way to normal, somewhere between asthma and COPD. And that's where we'd probably use the term ACOS, or asthma-COPD overlap syndrome. One of the things that we debate is how many people do have ACOS. As it turns out, it depends on who you ask, and from there, which definition of ACOS the investigator is using. What you're looking at is a graph of a number of different studies that have been published over the last 5 to 10 years. Investigators have looked for ACOS in different populations of patients, in different settings, and using somewhat different definitions. Across the bottom is the percentage of patients thought to have ACOS in the population. At the bottom, we see 3 studies that suggest as many as 50% of our COPD patients may have this overlap. But we think that's a tremendous overestimate, because those findings are based on questionnaires, asking people if they've ever been diagnosed as having COPD, also asking them if they've ever been diagnosed as having asthma. And if they can answer yes to both, they're considered to have ACOS. Well, that doesn't get us close to their real clinical condition. The other studies use clinical measurements, typically spirometry, to determine whether somebody had ACOS or not. And there we see estimates as low as 5%, as high as 22 or 23%. It's probably about 15 or 20% of our COPD patients who have some element of coexisting asthma or who have ACOS. Now, why do we care about this thing called ACOS? And as it turns out, people with this problem are a little bit different from your average COPD patient. This is another table, and I apologize, tables are always awful to look at, but I'll try and highlight the important things. This is from one of the larger and very good studies looking at ACOS and people who had ACOS, comparing them to people who had COPD without the overlap part. There were a couple of things that stood out in this study by Harden and his colleagues from the large COPD gene study. First, SGRQ scores tended to be much higher in patients with ACOS. What's that gobbledygook mean? It simply means that symptom scores were higher in people with ACOS. They had more difficulty with their symptoms on a day-to-day basis, more cough, more breathlessness, and so on. The other difference was around exacerbations, the chest colds, the lung attacks, the bouts of bronchitis. They occurred more frequently in people with ACOS than in people with non-ACOS COPD. We can see that clearly on this graph. First, you're looking at people with just plain COPD without ACOS. Some of them did have frequent exacerbations. Some of them did have severe exacerbations, the sort that land you in a hospital bed. A little over 15% for each of those categories. But here are the ACOS patients. By comparison, more than 40% had frequent exacerbations, that is, 2 or more per year, and a third of those ACOS patients had severe exacerbations, again, enough to land them in a hospital bed. So after a long description of COPD, asthma, we come back to alpha-1 antitrypsin deficiency, and what does this ACOS stuff have to do with alphas? Earlier I mentioned that there could be treatment differences for ACOS patients, and there were certainly treatment differences between COPD and asthma patients. The most important difference is around the use of steroids, and in particular, inhaled steroids. So there's the question for you. When do we use inhaled steroids for COPD patients? Lately, they've been used quite a bit, but when we look closely, we realize there's only one reason to use inhaled steroids in the average COPD patient. This odd-looking graph is the way doctors attempt to summarize multiple studies. Shown on this graph are the results of 11 studies in which patients with COPD were given ICS, that's short for inhaled corticosteroids, and what was measured was exacerbation rate, the tendency to have those bouts of bronchitis. In the middle, the dashed line that says 1 means that there was really no difference with the inhaled steroids as compared to placebo. If the line, the orange line that you're looking at, veers to the right between 0.5 and 1, it suggests that inhaled steroids are reducing exacerbations. If the lines appeared to the right, it would suggest that placebo was reducing exacerbations, or I suppose that inhaled steroids were increasing exacerbations. Well, those two orange blobs at the bottom, those little diamond-shaped indicators, tell us that when you add up those 11 studies, there's a small tendency for inhaled steroids to reduce exacerbation rate. It's not constant, not all the studies show it, but if you add them up, that's the impression you get. More specifically, adding those studies up suggests that there's an 18% reduction in exacerbations. It's not big, but then again, an exacerbation is a pretty awful event for the patient with COPD, so we'll use those inhaled steroids for the frequent exacerbators. That's primarily the patients with severe COPD, the ones whose FEV1, the ones whose airflow is below 50% of what it should be. Here's a complicated diagram, although it makes sense if you look up at the top and see that it describes what happens to some COPD patients year 1, year 2, and year 3. That's what those 3 sets of graphs refer to. And as it turns out, if you follow a large population of people with COPD, you'll discover that some of them, that's marked by the orange bars, will have lots and lots of exacerbations. 2 or more per year is the definition used in this study. It's called the ECLIPSE study. Some patients, the ones marked by the buff columns, will have essentially no exacerbations. So again, this is what we're looking at. Those are the frequent exacerbators, and you'll notice that the ones who have 2 or more exacerbations in the first year are likely to do it again in the second year and in the third year. It's a constant tendency, that is, to either have or not have exacerbations. And if we look at how many people have exacerbations, It turns out that it's a minority of our patients with COPD. So if we're going to use inhaled steroids in COPD, it's probably a minority of our patients who need them. And I'm going to remind you of this set of microscopic photos. On the left, the pre-treatment asthma airway, all of those inflammatory cells. On the right, a textbook picture of a normal biopsy. I'll now draw your attention to the explanation at the bottom. It says pre and post 3-month treatment with, and BUD stands for budesonide. It's pre and post treatment with inhaled steroids. Inhaled steroids make great sense in asthma, and people with asthma need inhaled steroids. So thinking about our overall subject, patients with COPD may need inhaled steroids if they're having exacerbations frequently, and they may need inhaled steroids if they are suffering from ACOS, the asthma COPD overlap syndrome. The sort of thing that we'd figure out if we used spirometry and saw that their airflow was quite variable over time, although never got completely better. You'll be glad to know I've reached my summary. First, COPD patients who don't have exacerbations or features of asthma probably don't need inhaled steroid treatment. These guidelines may apply to the alpha-1 antitrypsin deficient patients as well, some of whom seem to have pretty typical COPD emphysema, and some of whom seem to have features of asthma mixed in as well. In fairness, we're still learning about ACOS in general, and we haven't figured it out in the overall COPD population, and we certainly haven't done this sort of work yet in the much, much smaller alpha-1 antitrypsin population. We think the same lessons we're learning in general COPD probably apply to alpha-1. COPD is an obstruction or narrowing of the breathing passages that's persistent and has been produced by long-term exposure to irritants. In North America, probably tobacco smoke, but other things as well, especially if we look at a worldwide definition. Asthma, that's obstruction of the airways that's variable and can usually be made completely better with treatment, especially with inhaled steroids. And that asthma-COPD overlap, that's obstruction with features of both diseases. We can probably best detect it as a high degree of variability and the persistence of obstruction typical of COPD. ACOS patients, they have more symptoms and more exacerbations than the average COPD patient. Thank you.
This concludes today's featured presentation. On behalf of Alpha One Canada, I would like to thank Dr. Kenneth Chapman for taking the time to prepare and speak to our viewers. I do think it's very important that patients have a general idea of how their illnesses are diagnosed, and Dr. Chapman's presentation definitely helped us with that. Please be sure to check out the rest of our 2015 Virtual Education Summit featured videos on our website at www.alpha1canada.ca. Thank you very much and have a wonderful day.